All attendees are in listen-only mode.
Welcome to the American Indian and Alaska Native Behavioral Health webinar series presented by the National American Indian and Alaska Native Addiction Technology Transfer Center. I'm Karen Summers and I will be administering today's webinar. Today, members of the White Earth Nation Harm Reduction Coalition, Sarah Rybecki, Clinton Alexander, and Karen Keller-Hoos-Coleman will be presenting HIV-HCV Harm Reduction Coalition Development, How Tribal Communities Can Develop Their Own Coalitions. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the states served by each of the regional ATTCs. To learn more about our center or the network or your regional center, please visit our website. Our next webinar in this series is scheduled for Wednesday, August 7th, where Harold Tarbell will be presenting Using Multiple Techniques to Facilitate Strategic Planning. In addition to this webinar series, we offer another series titled Essential Substance Abuse Skills Webinar Series, which provides an overview of competencies from CSAT's TAP 21 publication, Addiction Counseling Competencies. The next session in our Essential Substance Abuse Skills webinar series will be held on July 17th from 1 to 2:30 Eastern Time, where Bob Raritt will present on treatment knowledge. Our center is a NADAC certified educational provider, and we're happy to provide you with CEUs. The cost is $10 to do so. The CEU request form will be sent to you within 24 hours of today's session. If you do not receive the email with the handouts within 2 business days, please let us know. In addition to the CEU request form, a consent form and information about participation in our GIPRA evaluation will be attached to the email you receive following today's webinar. We ask that you fill out the consent form and return it by either email or fax. If you agree to complete our evaluation, you will receive a link inviting you to participate in a brief online customer survey. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering information about our services by participating in our evaluation. Before we start today's session, I'd like to give you a quick overview of the GoToWebinar tool, or GoToWebinar system. To hide or expand your toolbar at any time, you can click the red arrow on the top right side of your window. To expand your screen, click the middle button in the top right-hand corner. You will be muted for the duration of this webinar. Please use the question chat box to share your questions and comments. Your questions will only be visible to me, the webinar moderator. I will pass your questions along to the presenter at appropriate points in the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEUs received. The opinions expressed in this presentation are those of the presenters and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. Today's presentation is made by members of the White Earth Nation Harm Reduction Coalition, Sarah Rybecki, Clinton Alexander, and Karen Keller-Hoos-Coleman. Sarah Rybecki co-directs the Minnesota State site of the Midwest AIDS Training and Education Center in Minneapolis, Minnesota. Ms. Rybecki is a coalition supporter and has over 15 years' experience in HIV, AIDS, and hepatitis. Clinton Alexander is a founding member of the White Earth Nation HIV-HCV Harm Reduction Coalition. Currently, Mr. Alexander serves as Executive Program Director of a Sexual Assault Services Program and Project CEDAR. Karen Keller-Hoos-Coleman has been involved in infection control for the IHS White Earth Health Center since 2007. Ms. Keller-Hoos-Coleman has experience addressing infection control with the Minnesota Department of Health Hepatitis C Division. Along with Mr. Alexander, she is a founding member of the White Earth Nation HIV/HCV Harm Reduction Coalition. Please join me in welcoming Clinton Alexander.
All right. Hello, can you guys all hear me okay? Can you hear me, Karen? We're coming off of mute. I want to make sure you can hear me. Thank you for this opportunity to share our knowledge. That is something that we strongly believe in. Say hi, and Sarah, say hi as well.
Good morning or good afternoon all. This is Karen Coleman.
Good afternoon from Minneapolis. This is Sarah Radicke.
So we are talking about the work that we're doing in northern Minnesota. You can see on this little box, we're from the Gawa Babi Ganikag Nation, the White Earth Nation in northern Minnesota. To start with, it's kind of hard to just dive in where we're at, but we wanted to kind of highlight and show some of the background information that we had as we began to move forward as a coalition and pulling together our resources and leveraging that. When we looked at the IHS National HIV Administrative Work Plan, we saw there's 7 components of it. We looked at that. And then the second part that we really explored and wanted to make sure we were including, we're having a little problem with my slide. When we looked at IHS's guiding principles, there are a couple things that jump out at us. The collaborative, integrative, the community involvement, the confidentiality, the respect, the cultural awareness, and fluency, and progressive. And we really kind of looked at that as, I think, instead of reinventing the wheel, how do we take those components or those principles and how do we adapt that? Because in Indian country, we tend to operate in too many silos. We don't share information with one another, or we go on a completely different page. And I know for myself, working with a community-based program, I needed to know what are the things that IHS has chosen as their guiding principles, and then how do we go in then and talk about it from our perspective and what it means to them and their programs. And as Karen shared at the introduction, I work with Sacred Spirits, which is a coalition. We've been in existence for just over 11 years. Our mission to reclaim the sacred spirits of women, men, and their families for the next 7 generations by healing the effects of historical trauma through culturally competent practice, utilizing Anishinaabe values and beliefs. And that's really, when you think about historical trauma, when you think about what we're trying to do as a program, it has very wide-reaching objectives within that scope. I know many people have seen this. This is something that it's easier for me to use a quote like this or a proverb like this to kind of underscore really our intentions as a program and what we're trying to accomplish. A few years ago, we had coalition members, this was about a decade ago, who, while we were discussing the need to address domestic and sexual violence on our reservation and our communities, we had a community member who kept bringing up, what are you going to do about HIV? There's going to be some issues with this. That our elders had shared this 10 years ago. What are you going to do? This article to us spoke to us because we saw the intersection of sexual assault, injection drug use, and HIV risk. And it's a great article. It's easily found. Many sources have that. But for us, it was really a logical connection, the gender-based violence linked to HIV, and taking a holistic approach and understanding that we as a community-based program, even though we weren't a medical provider or a healthcare program, we had a need to help and be part of this approach. Another article just recently was published, Keeping Our Hearts from Touching the Ground, another excellent article that talks about this. a little background about our community. When we started looking at some of the things, obviously we know that Native Americans typically are, when you look at social economic determinants, social determinants, Native Americans typically are at the top and bottom of every list that you don't want to be on. And we're not going to spend a lot of time because I think we all know that very well. But some of the things that really stuck out with us is that one of the counties that's completely encompassed within the boundaries of our nation also for the last 5 to 6 years have remained in the top 10 counties in the rates per 100,000 for chlamydia and gonorrhea. To us, that was a very strong indication that the behaviors are happening that put us at increased risk for HIV transmission. And again, I believe you will be given a copy of this presentation to read through this, and it's a lot to read, so I don't want to do that because I think we can all do that on our own. But we did see the numbers. We saw these rates increasing, and we know that even though Native Americans typically are sometimes invisible in this data, we knew that if this is happening if we can find this information in our counties, we know that that's giving us that background that we need to frame this work. So here's this next slide's a timeline, and it doesn't go in linear because before 2010, we had 3 main local programs that were working to address HIV. We had our White Earth Tribal Health programs, particularly the health education, who was doing STD 101 information in the schools, puberty classes. Of course, we had our IHS program, who was doing the work that they were doing within their organization, and then we were doing ours. When we went in and did healthy dating with our teens, our elders were telling us to include comprehensive sex ed, even though at that time the administration, the federal guidelines were not to use that. So we also knew that there were also some regional HIV programs that were doing this work too, that would come up onto our nation, do screening events, programs that were serving natives living with HIV or AIDS in our communities, and we knew that there was a need for us to start working together. Some examples were the Indigenous Peoples Task Force, located in Minneapolis, which is about 4 hours southeast of our nation. RAN, which main headquarters is in the central part of the state of Minnesota, and the Minn-Kota Health Project, which is located in Moorhead, Minnesota. Around this time, White Earth was selected to do a new national initiative for universal screening, and with that we began a new partnership. We had our program director and myself had taken part in a CDC-sponsored training through SAMHSA to go through the counseling, testing, and referral program, because we said we need to be providing rapid screening in our communities, particularly for victims of sexual violence who had never ever had that opportunity to be screened and have that peace of mind to just know that they hadn't been exposed to it. And around this time is when we did our first testing event, and we'll get to that here in a second, but I do want to talk about how this universal screening initiative through IHS for HIV began, and Karen will talk about that next.
In 2009, the IHS, Indian Health Services, am I talking too loud? I'll try to tone it down. They started what they call the GIPRA numbers, and that's what the government looks at and tries to focus on, that all IHS clinics address these issues. And because the Native American population was found to have HIV at the much later stages, they felt it was very important to try to catch the screening early on, and that's why they put this on their radar, or their GIPRA. And in 2009, that's what we started to do. We made it a national goal to screen everybody at least once, ages 13 to 64, and any time in between that the situation or their personal lifestyle had changed. When we did that, we were noticing that the nurses and the providers were a little bit scared, didn't know how to talk, didn't know how to bring it up, because it was, oh my gosh, this is HIV, and how do you talk about that? So talking with Clinton in Sacred Spirits, he was willing to come in and talk with our group, and along with Maytech, they came at another time. So with their collaboration, we were able to train our nurses and providers, and they became a little more comfortable, which really helped. We started seeing our numbers of screenings go up with our GIPRA numbers. But with that surveillance, we also noted we were not giving the education behind it. So again, we had Maytech and Sacred Spirits come in and tell them what, or not tell, but train us what we should be educating our people with as far as high-risk behaviors or protection when you're planning on to have sexual relationships, etc., etc. Our numbers in training did come up. Our numbers in HIV came up. And glad to say that our nurses are a little more comfortable with that. We did feel a little resistance from some of the clientele, our patients coming in, that they really didn't want to do this. But once we did the education, they were a little more apt to do it. I'll turn it back over to Clinton.
And at this time, again, things were going on simultaneously for all of our programs. And like Karen said, the numbers were up. Karen came to us and said, hey, we're testing about 100 and some people a month, but we have zero follow-up or patient education that's occurring at the time. So we utilized a resource from the National Native American AIDS Prevention Center on working with providers. We did some values clarification, some skill building with nurses and the direct patient care staff, and we immediately saw a spike. And later in the presentation, if we have time, we do have a slide that does show where you see that. We had, at that time when we started doing our screening for HIV, we had also established a really close relationship and with the Minnesota Department of Health, their HIV STD section, Sarah Gordon, who is still with them. And then when I talk about Sarah, and we get to the slide that talks about our coalition and our allies, over just the last couple of years, and I know that our coalition, if they were all on here talking, will speak to this, that we really feel more like a family than we do as programs. We really represent from our heart, and that's a thing that you can't really put into a slide or really demonstrate that. But the Department of Health really became a strong ally. They took a risk with our program. They knew that this leveraging of resources was going on. They allowed our program to be a pilot project. So I know that from the Department of Health, that was a risk that they had taken to really show that in good faith they support what we're doing, and that they respect what we're doing, and that we as Native people should be leading this initiative. So as these things were occurring, it does show that on our slide that our IHS was one of the first in this pilot project, one of 5, to roll out this project to do testing. We work closely with them. As part of that, we talked about National Native HIV/AIDS Awareness. And in 2010, we held our first collaborative event in which we'd asked the National Native American AIDS Prevention Center, the Department of Health, we asked Maytech. All partners were part of this, and we came together. We did the 101. We did rapid HIV testing. The tribal health programs also set up tables. We invited programs to display, to do what they do when they're in that environment. We after this event, White Earth Tribal Health health educator Kim Turner, myself, Karen Coleman, people from the Indigenous Peoples Task Force, RAN, Minn Kota, we went and had a meal. And at this meal, we sat down, and one of the first topics we discussed, there were several things that were discussed, but 2 of the ones that really stick out as I think key concepts for us that kind of cleared the air. One of the first things we said was, if you're not here in a good way, if you're here to try to take advantage of the situation, we know that there's a lot of competition for grants. We know that there's a lot of territorialism. We needed to rise above that and understand that this issue we're talking about, and this is the second concept, that the issues that we're talking about are bigger than my program. It's bigger than IHS. It's bigger than our tribal health programs. It's bigger than our partners programs. It's bigger than all of us combined. And that if we're not here in a good way to address these issues, we're not gonna succeed at what we need to do. And it really there was that feeling of, yes, we can commit to this. From that summer, we did our first social media event, focusing on a Anishinaabe traditional story, which we'll share at the end, of how the fly saved the river. We adopted Ningi Kenjige as our motto, as our logo, however you want to frame it. It's Ojibwe for I know, and with that we felt that encompassed I know about HIV. I know how to protect myself. I know how to protect my family. I know how to protect my community. I know how to get tested. I know my status. So many different ways that we could frame that. And from that, we continue to talk about the need to continue to work together. And we'll go a little bit further with that. But in fall of 2010, a new component was added to this mix, and Karen from IHS will speak about that.
And in 2010, I was working with IHS as their infection control officer. And when STDs, HIV, and hepatitis C was found, I had to report it to the Minnesota Department of Health, and I kept a log of what was found. And all of a sudden, I had 10 cases of hepatitis C, and I thought, what the heck is going on? And so I just dialed the 1-800 number to the Minnesota Department of Health, and they gave me the hepatitis C specialist, Sherry Booth, and she said, well, let's sit down and start figuring this out. And she said, you know what, I think we have to declare this as a cluster outbreak. And when we did that, just in the month of October of 2010, we had 16 people with the screening of the antibody hepatitis C that were positive. And when they came in, Minnesota Department of Health, we figured, let's get everybody else on board, the ones that we already had in that are our neighbors, our tribal education department, our tribal health nursing, and our sacred spirits. So all together we sat down, we decided what to do. We wanted to call all these patients and do an interview and gather data to find out what happened, what were the risk behaviors, if any, was there something going on, what happened. And it came to find out it was 2 different communities, but with there was a few family members, but then there was some other party things going on. But that didn't matter to us. What mattered to us was, as we talked to these patients, teaching them the safety of not sharing needles, not sharing razors, the toothbrushes, and how to keep themselves safe. And if they were wanting to change anything in their lifestyle, we would help with that. And at that time, and since then, we have just really formed this big, tight-knit family. Like Clinton said, we're not a program. We do call ourselves a coalition, but maybe we should say it's a family coalition, because we're all here because we care. It's not because of a job, it's just because we care. And I shouldn't say just because it really, really means a lot to me. It has affected my family, it's affected my neighbors, and I want to make a change. And I'm hoping that many more people will just get on the bandwagon with us. And that's what has happened since 2010. In 2010, after this outbreak, we decided we need to educate our people. And so in 2011, we had our first Hepatitis C Summit. Guess what? I was hoping we would have maybe more than 32 that was at our HIV conference the year before. And guess what? We ended up with 75 that came that first year. And that last year, just this year of 2013, we had 150 community members, providers that wanted to learn so much more. And you know what? I have a feeling next year it's just going to keep growing and growing because everybody wants to learn, because we want to help. Okay, I'm on a soapbox, but I want to get you guys fired up. You can do this. Just reach out to your neighbor and say, do you see what's going on? We care. Let everybody know you care. Okay, I'll turn it back over to Clinton.
And this probably speaks to something, I think, when you look at the dynamics of our family, our team, our coalition, that Karen really is our champion of let's get out and do this. I think we all can look at our, who we work with on a daily basis and look at the different skill sets that we can bring to the table, and not only leveraging our resources but leveraging our skills. And I think, as you just heard, Karen really brings that piece to our group. Karen has no problem standing up in a group and bringing home the importance of these health issues and bringing it out and talking about it in any kind of setting, because we can't talk about it only in that patient room. It has to talk in the community. I think just to kind of, when this cluster was identified within our tribal villages, it really struck close to home for a lot of us. It also then, as a coalition, told us that we shouldn't just be focusing on HIV, because we know that there are a lot of shared similarities in routes of transmission for hepatitis C, things like that. So we did include hepatitis C within the focus of our coalition, and harm reduction just naturally came along with that. And I think from what we were learning about harm reduction, to us, we felt harm reduction was almost an indigenous value. This was a native value. I know that I personally believe when we talk about the honor of one, we have to talk about, the honor of one is the honor of all, but what about the hurt of one? Isn't that the hurt of all? And I think we can look at our traditional teachings and our values and really speak to that. But there was also, at the same time, a state of emergency declared, and I know that our tribal government really kind of led the way on this and declared a public health crisis, that prescription drug abuse was going on, and this really kind of spoke to what we already knew. The headlines that came out at that time really reinforced the need for us to do this. The HCV cluster found in Becker County, I know it made the NPIN bulletin, cluster identified. So I do believe from the state's point of view there was a need for them to respond, but we'd already established this relationship, so it was not, oh, here comes the scary government people in to save us, or those things that we kind of visualize in our heads when we think of these things. We had those relationships established, that it all came together very naturally. Our Whiter Tribal Council declares the public health emergency. Our chairwoman said it very specifically. We need to take down our fences and work together. It's not unique to our tribe. It's not unique to our nation. It's a nationwide problem. Our secretary-treasurer says all of our families have been affected by these issues. We need to get away from the blame game and stop letting us drag us down. It was at that time that we transitioned right into, well, then let's ask for a resolution. Our coalition has developed. We're approaching these issues, and this resolution was nothing that the resources are there. The National Native American AIDS Prevention Center and their partners have these templates available to you. What we did is we wanted to go in and just make sure that there's strong support for what we were doing was there. You know, harm reduction is something that is sometimes controversial, and this does not say that our tribal council, our tribal leadership necessarily endorses harm reduction policies, but they will speak to that, what they said, it's time to stop the blame game, tear down these fences. It's not business as usual. We need to take new approaches. And as our community is continuing to be mobilized by the efforts of our coalition, through the efforts of our coalition, we see that this makes more sense to more and more people. This is not a scary beast that we tend to think of when you talk about harm reduction on some levels. These are, when we were writing for funding to support this, you know, I think maybe some people are sitting there going, well, where did they get all this money to do this work? We talk about coordinated community responses. We talk about leveraging resources. We wrote a small grant to the Office of Minority Health Resource Center to strengthen through Sacred Spirits, our testing ability or capacity. And we adopted these as coalition goals to increase awareness by promoting educational opportunities with the goal of reducing stigma and engaging people to participate in identifying their health risks, to enhance our capacity to make sure that it's culturally appropriate, and collaborations and strengthening partnerships, and to increase the access to HIV screenings. And that really was a big part of this push to normalize testing. Did you want to say that? Okay. And in this slide here, you see, you know, Ningiginjigay, this is kind of our way of mapping out how we kind of came together, who our programs were. And really this is an older slide. It doesn't share all that. And at this point, I do want to invite Sarah Rybecki from Maytech to talk about her role in what we've all been doing. If you look at this, the left slide shows kind of the main foundation of our programming. We look at our collaborative partners that specifically address HIV, but then we go down to our support and allies. And I'd really like to have Sarah speak at this time.
Thank you, Clinton. So I think what was most exciting about working with this group as an AIDS education and training center was that I arrived with very little idea about how to work in an Indian community and very little idea about how to work with the IHS, and pretended no expertise at all, and really opened my ears and said, I want you to tell me what information you would like. I spent a lot of time meeting with people in coffee shops, in the IHS nursing stations, and in conference rooms, and talking to them about what they needed and what they would like for education. We took a very slow approach, and because a lot of our collaborating partners had trouble getting away from their incredibly busy jobs, we committed to going to this particular corner of Minnesota and focusing on the area around Bemidji, which included the White Earth Reservation and the IHS and tribal health services there, once a month for about 6 months. So we would just go and be available during that time to meet with people, and after a while the word got out that we had resources to share, and then we were able to do that. Slowly, initially, because we weren't really sure what folks needed. But then as it became more clear that the community wanted, I would say, information that came from each of these agencies, we were able to provide CE and CME. Other agencies were able to provide testing and counseling trainings. We all kind of pulled together and met needs together. And because of the incredible communication by the coalition members, it was very easy to see how any little piece that we brought built up the whole system. And we didn't feel, I think, ever like we didn't know what to do, because we had such great information from our local contacts about what they needed, and we were able to bring what they needed. And I think that the excitement built as each person was allowed to do what they were best at, and that has been a philosophy that I think we've all really enjoyed, that we were able to shine at what we did the best. So if they needed help with evaluation or access to speakers or registration, those were things that I knew how to do, and I was welcomed, and I very much welcomed the skill sets of other people who were there to tell me about what was needed and to give me direction. So I think it's been an amazing collaboration between all of us. I think that one of the more exciting parts too has been that there really hasn't been a line between HIV and HCV and substance abuse and mental health, and it's all sort of seen as the same problem, which is not common, and I think in doing necessarily in doing grant-funded work. Everybody had this very holistic, organic view, and so there was never this point where we had to persuade anybody that HIV didn't belong at an HCV conference, or that HCV didn't belong at an HIV conference, or that we were talking about this kind of drug user or that kind of drug user. It was, or this kind of sexual behavior or that group. It felt like one group, and I think that goes back again to the coalition and how crystal clear their thinking was on all of these things, and how integrated it was, and really what a beautiful job they were doing. So I would like to open up the presentation at this point for some questions, because if there are those of you out there who have questions that you've really been wanting to ask, I want to make sure that they get addressed before the end of the presentation. We have more to talk about, but I'd like to ensure that your questions are answered. So if you want to go ahead and ask them, we'd be happy to entertain a couple questions.
So at this point, if you have any questions, please go ahead and type them in that question chat box, and I'll go ahead and pass them on to the presenters.
Being there's no questions and answers at this time, this is Karen Coleman again. I just want to make sure that people don't feel we are picking on a certain group or high-risk behavior people, because as we are doing all these screenings, we're finding out there's so many baby boomers out there that have the positive Hep C, and that happened because of blood transfusions back in before blood was screened. It's happened because of tattoos. It's happened because of whatever reason. And just like the HIV screening, we have to screen for the hepatitis C, because if we catch it early, we have a much better ending, that we can give them a healthier life before the end. And that didn't sound right, but do you know what I mean? Yes, you do. Thank you.
We do have one question. So the first question is, why is the integration of HIV and HCV so easy for this population versus any other populations?
Clinton, would you be able to take that?
Why?
It looks like they've added a clarification. HIV, HCV training.
I think when you look at the limited resources, when you talk about the prescription drug use, the routes of transmission, you look at injection drug use being a common theme in there. You look at some of the the article that we used, the triangle of risk that for our program specifically. The two viruses are transmitted very similar, and for us, what we really identified at that time was that HCV was not on anybody's radar. No one was talking about it, but yet we're going into the communities, we're providing information on, if you are using needles, clean them, but we felt that with such limited resource, such focus from anybody on these two issues, for us, it did make sense for us to continue to move forward and think that we need to talk about HIV in its own silo. Not saying that that one and another are the same, but there were a lot of similarities, and for us, it would have been futile to keep moving forward without addressing that issue. And really a big part of it really came from our cluster, and our coalition was developed, and we had these relationships, we had these resources. You know, we called out. Sarah, I know that you work for the Midwest AIDS Training and Education Center. How do we start moving forward addressing hepatitis C? We did the same thing with the Minnesota Department of Health. Sarah, what should we do? The relationship with the hepatitis C coordinator was already established. We brought that in, and to us that was logical. I don't know, Sarah, if you have anything that you want to piggyback on with that.
I agree with everything Clinton said, and I think it's a marvelous question because others have asked me that question also. I would say that for me it was very simple because the community had such a strong idea already that when you actually were there in the community, these kinds of that there weren't two separate disease states. That's not how people thought about it. So what I was asked to do, I did. And it was much easier than coming in and saying, I need to bring any kind of specific training. I said, what can we use as the platform where we start and then begin the change process slowly? And I noticed right away that HCV was, at least in my experience, somewhat less stigmatized than HIV was. So beginning conversations about HCV leading to distribution of clean needles, leading to condom use, I mean, that was very appropriate. And some of the same kinds of trainings just worked very naturally and beautifully for HIV and HCV, but HCV was our starting point because that was where people's interest was, that was where the cluster was, that was where less stigma was, and I thought, okay, let's just start there. And we'll work our way to wherever we need to be, and again, that process was very easy.
Okay, our next question is about the stigma. So could you expand a little bit on the stigma and if there's differences in stigma between the two diseases within the population that you're working with?
Well, you know, I think one of the writing on the wall stigma that sticks out the most is I think that many people, all too many people, have identified specifically HIV as being a gay white man's disease. In our communities, on some levels, we tend to, you know, we have this attitude or this community belief that it's not in our communities, that's only in the big cities. We don't have it. Reality, we had community members coming forth sharing their concern. I have a relative who's living with HIV. We can look at state surveillance. We knew that it was here. We also know that when we talk about hepatitis C, we know that one of the biggest concerns, and we still see this when we go out and do a needle cleanup, we have a lot of people who, I'm not a junkie, you know, there's that stigma that hepatitis C is only spread through injection drug use. So we've made sure to talk about those issues, that it's veterans are at increased risk, baby boomers are at increased risk. We wanted to make sure we did that. And so I think, you know, there are many ways that the stigma is there. The testing. If I'm seen in the community getting tested, are people going to think, one, are they going to think I'm gay? Or are they thinking I'm an injection drug user? When we know that HIV is transmitted through heterosexual sex, acts of sex. So some of the initial steps and part of our belief was to make sure that we provided that information out there to address those issues of stigma. That it's not a gay white man's disease, that you can get it. But I guess, and this is I go right back to this, we saw in our statistics, our chlamydia rates were really, really high. So we knew that in those other ways that HIV is transmitted that aren't as stigmatized, we knew we could capitalize on that and continue to increase that level of awareness and knowledge in our communities.
Thank you.
This is Karen. I'm going to also add one more thing. When we are doing this. The community has come to know us as a coalition, and they trust us. They know that everything will be kept confidential, and that's very important to them, is that confidentiality. And they know us as a coalition, that they can contact us either about any of those things, or if we don't know the answers, we'll find that for them. And it's just sort of neat to see the community members come out of their house when we're out picking up needles, saying, well, go over there, that's where there's some more. And then they start sharing more information. And the more we make ourselves visible as a coalition, as a tight-knit family, they trust us, and we become part of their family, trying to help each other.
Thank you, Karen.
Welcome.
So if there's no more questions, we'll just kind of go into a couple more slides here to talk about where we're at today, and then just a couple reference slides. If you look at your screen, this is who our coalition is now comprised of. And by talking about our coalition, what I want to make sure people understand is that we do meet monthly. We meet for about 2 hours once a month. We come together, we talk, we share things that we're doing, we troubleshoot, we talk about things we could do together, we do our planning, and again, it's using existing resources, we share a meal, we come together, we do bond in that way, and I think there's something to be said about that environment, you know, keeping it, for us we call it keeping it real. But our current coalition now has active participation from, we originally had White Earth Health Education, with the cluster, we brought in home health, it brought in substance abuse, and then the request for people to join the coalition is beginning to increase again. We have White Earth law enforcement. We have a police officer who sits in and understands that from his perspective. We know that harm reduction, needle exchanges, syringe services are endorsed by many national law enforcement programs, but law enforcement also, our law enforcement, our public safety department is really taking an active stance in understanding that harm reduction is part of what we need to do to break these cycles. Our White Earth Health Center, we do have a great relationship with them both locally and on the national level. The RAN, Rural AIDS Action Network, Sacred Spirits, and Indigenous Peoples Task Force. When we do our events, we come together. These programs lend their support. All three programs may be, you know, providing testing at the same time. Some are doing what's best, or what they do best, doing the 101s. Some people do the organization, things like that. And again, I want to speak to the allies part. I know that sounds very sterile or very whatever, but these partnerships we do take very personally. We do have a close relationship with these programs, and I encourage people who are struggling to develop these kinds of relationships to reach out to these programs to ask them from their perspective what they've learned. One of the slides I spoke to earlier, you can see very clearly on this, the jump in education. When we came in, where is it? Maybe it's the next screen. There it is. I apologize. If you look at that, the education that came in, and Karen having that access and that relationship through the coalition, we came in and we saw that jump from 3 to 25 in just a very short time, so we knew that we were meeting the needs. I think, you know, if you go to that one. This, and Karen spoke to this, this is another excellent example of us working together to leverage resources. Our first year that we did this, we said we want to do something around hepatitis in May. We reached out to our partners and said, what can you help us with? What resources do you have? We all have limited resources. I can provide my time and efforts to do the HIV, hepatitis C 101s. Maytech, what can you provide? Minnesota Department of Health, can you send somebody? We didn't need to go out and find grants to specifically support this. And Karen spoke to the success. I think we saw our numbers doubled. But one of the things that came from this, we know the statistics around hepatitis C, that was really serving. But when we did our assessments, we asked while the participants are there, we wanted to share this. We did a World Cafe, we called it Res Cafe. We wanted to engage people and get their feedback right there. But these are some of the comments that were made. It was a great collaborative effort. So that to us, I think to me really spoke that they saw that this was a collaborative effort. I think that's a great thing to hear. Looking for years to come, we inspired people. Now I know what we can do. That was one of our goals in holding the summit, was to inspire people to do what they can within their role. And again, this came from the support that we had from our partners. We asked, what will you do differently? They understood that this problem was deeper than they probably anticipated. They needed to do more solution-oriented planning. To the simple, listening to my client, trying to tune in more. Work more thoroughly on my case plans. I know the first year we brought in a partner who could share information on enhanced risk assessments and incorporating both HIV and hepatitis C into that assessment. I think how we can improve. They want more leadership involvement from tribal, law enforcement, IHS doctors. And I know that we hear that all the time. We need more involvement, and we take this seriously. So we continue to develop relationships with our tribal council members, those that where this was something that was on their radar. I know that our Secretary-Treasurer, this is something that he felt in his heart was something that we needed to talk about. We had the proclamation from our tribe, we had the public health crisis, all those things. We capitalized on it, we focused on that and said, this is how we're doing this. The next steps, we knew that for most of our programs, we were locally based, we were tribally based, but with our IHS partners, we wanted to talk more about how do we include harm reduction into the healthcare environment. And that, again, was a partnership with both Minnesota Department of Health and Maytech. How do we incorporate this into these provider training that programs like the AETCs can provide? How do we make sure that that's in there, because we know that that's going to go into the community and it's going to be part of this approach? How do we look at the linkage between our effort and this emergency? And again, I can't underscore that enough. We want to talk about pain management education, the appropriate use for pain medications and things like that. And again, outside of the realm of the work that I do, but we had that relationship with Maytech, with the Department of Health, with IHS. It was easy, it was natural. So as a coalition, as we come to the end of the conference call, next steps for us, the things in bold are planned or have taken place. We go out as a coalition when we're able to do community cleanups. We go out. We responded impromptu this spring in the middle of 28-degree weather. We got a call from a Head Start that some syringes were found near a playground area. It spoke to all of us. As we understand that for a lot of people, it's very easy to get angry. And those emotions need to be, I think you need to process that. And I remember sitting in the car being, trying to be this champion for we need to keep doing this and we need to address these issues, but that anger kept welling up and saying, who the heck, not the words I use, but where's the common sense? But again, you have to pull yourself back and remember that this is a bigger issue. Overdose prevention is huge. In our summit this year, we had a presenter from the National Native American AIDS Prevention Center that provided a workshop on basic life life-saving measures that you can take, how to call in a 911 call. We want, as a coalition, we want to bring enhanced training on heroin opiates. We know that the community needs to be aware of these issues. We're working with the State Department of Health and Maytech to do a hepatitis C educator certification so we can get more people in our programs, our providers, our home health nurses, people who are in the community to have more accurate information on hepatitis C. We know that treatment is a ways off, or sustainable treatment or affordable access to this treatment. As we identify people who have hepatitis C, we need to make sure that we're educating people. The support groups, digital storytelling, testing events, we're continuing to do that, ongoing harm reduction using the evidence-based approaches. The rapid HIV counseling, testing, referral, and training and linkage to care training, we just completed that, and that was, for me and for our coalition, a huge success. We had 15 members we had substance abuse program directors and their staff. We had law enforcement signed up for this. We had home health nurses, our program. We partnered with the Department of Health, the National Native American AIDS Prevention Center to bring this training to our reservation. We now have this team of 15 people who are trained not only to do testing, but the next step. NAPC has adapted the ARTIS intervention, the linkage to care, to a positive wellness model that's more Native specific. And for us, that's a huge thing because we're at the forefront of this new strategy, and we've already brought this kind of training to our people. And social media. But before we leave, when I started, I talked about how the fly saved the river. And this to us is something that speaks to us, and I will read this to you. Many, many years ago when the world was new, there was a beautiful river. Fish in great numbers lived in this river, and its water was so pure and sweet that all the animals came there to drink. A giant moose heard about the river, and he too came there to drink. But he was so big and he drank so much that soon the water began to sink lower and lower. The beavers were worried. The water around their lodge was disappearing. Soon their homes would be destroyed. The muskrats were worried too. What would they do if the water vanished? How could they live? The fish were very worried. The other animals could live on land if the water dried up, but they couldn't. All the animals tried to think of a way to drive the moose from the river, but he was so big that they too were afraid. That they too were afraid to try. Even the bear was afraid. At last the fly said he would try to drive the moose away. All the animals laughed and jeered. How could a tiny fly frighten a giant moose? The fly said nothing, but that day, as soon as the moose appeared, he went into action. He landed on the moose's foreleg and bit sharply. The moose stamped his leg harder. And each time he stamped, the ground sank and the water rushed in to fill it up. Then the fly jumped all over the moose, biting and biting and biting until the moose was in a frenzy. He dashed madly about the banks of the river, shaking his head, stamping his feet, snorting and blowing, but he couldn't get rid of that pesky fly. At last, the moose fled from the river, and he didn't come back. The fly was very proud of his achievement and boasted to all the other animals, even the small can fight the strong if they use their brains to think. So with that, thank you, Miigwech.
Thank you.
Thank you, guys.
Thank you.
Thank you, Clinton.
So once again, I'd like to thank Sarah Rybecki, Clinton Alexander, and Karen Coleman for sharing their knowledge with us today. And we'd also like to remind everyone to please watch for our email with the handouts for this webinar. The attachments will include your CEU request form and the GIPRA consent form, and we appreciate your decision to participate in our GIPRA evaluation, as completion of these forms allows us to show SAMHSA the number of people served by our webinar. To participate in the GIPRA evaluation, return a signed consent form to our center by email or fax. We hope you will be able to join us for our next webinar in the series. On August 7th, Harold Tarbell will be presenting using multiple techniques to facilitate strategic planning. We also hope you'll be able to join us for our next webinar in the Essential Substance Abuse Skills webinar series on July 17th, where Bob Rarrett will be presenting on treatment knowledge. And finally, we'd like to thank all of you for participating in this session today. We hope you've enjoyed the session and look forward to hearing your feedback. Thank you.